Hey guys, hope you're doing well. Welcome back and hope you had a good week. I think it's been a bit of a tough time for everyone with the revision. I hope you're all doing okay and that it's going well for you. I think it has been a bit difficult generally, also because it's now the holy month of Ramadan, so it's a pretty tough time to be revising as well for some of my friends and things, and just wishing you guys all the best with that and hope it's going okay. Today we're going to be looking at clinical psychopharmacology part 1. So this is divided into 2 sessions, this week and next week, because it's one of the bigger topics. Again, 25%, so that's 37 or 38 marks. And as always, I've tried to cover the key points, the most high yield information, but this is a very, very big topic, and there's so much content out there at the moment for this topic. I've, as you can imagine, tried to look at everything, but it's kind of impossible to be able to cover everything within the sessions. But I'm hoping that what we do cover is kind of, at the very least, the most essential things, and that you can supplement that with what you're doing already in the question banks and mock exams as well. So we'll crack on and see how that goes. In the syllabus, it's kind of divided into initially the general psychopharmacology. So these are things like the history, classification, and then all the kind of like drug trial stuff like that. So we'll go through everything kind of step by step in there. And with the history and evolution part, I would say that I wouldn't get too kind of hung up on that, like learning the dates or anything like that. As far as I know, in questions, they tend to ask more about the name rather than the specific dates, unless anybody's had any different experiences. But most of what I've seen has been kind of naming the person. So let's go on to that. So in terms of historically, so these are kind of the main people that come up in this topic, but as you know, there's lots of other people's names. For example, from the first subject that we did, the first topic, which is the sociocultural psychiatry aspect, that is very much sort of person and famous name heavy. So that is also something quite relevant in there. And, you know, maybe worthwhile just kind of pulling all of the names together and seeing if you can put some flashcards or something. Another useful thing that I did was I recorded myself saying all of these, and then I just played it like in the car on the way to the exam, because I think it's kind of short-term memory stuff for the names, to be honest, although a lot of the stuff is short-term memory stuff, so maybe worth learning it properly. We'll just run through them in case anybody finds it useful to kind of hear the terms as well as see them, and that can be very useful for kind of memorization and learning. So we'll go through them. So MONIS, frontal leucotomy in psychosis, SACEL, insulin shock therapy, Chiletti and Bini, responsible for ECT. Lurie coined the term antidepressants, kind of like my name, almost, Lurie. Delay and Denica coined the term neuroleptic and also introduced chlorpromazine as a schizophrenia treatment. Charpentier synthesized chlorpromazine. Klein sort of found or discovered the first monoamine oxidase inhibitor, which is ipronizid. Cade was the first to utilize lithium in mania. Blackwell described the cheese effect in monoamine oxidase inhibitors. Meduna used metrazole therapy. Kane was responsible for the clinical reintroduction of clozapine, sort of in clinical practice. And then Kuhn was kind of involved in imipramine's antidepressant effects and how that came to be used. So I'd say, yeah, those are probably some of the key ones that are in the sort of that cross over most of the questions and things that we have, like sample questions, but obviously there's a lot more names and things, so just probably start with these and see how that goes. And then the next thing that we have on the syllabus is this classification of kind of compounds and groups of psychotropic compounds. So we first of all start with looking at the typical antipsychotics, also known as the first generation antipsychotics. So these are haloperidol, sulpiride, suclopentixol, flupentixol, chlorpromazine, perfenazine, and trifluperazine. And obviously all antipsychotics reduce dopaminergic transmission, but these conventional, typical, or first generation antipsychotics also affect the M1, alpha 1, and H1 receptors, but their primary blockade is on D2 receptors, and that is also why they have kind of a lot of the EPSEs, and they've got a lot sort of stronger side effect profile compared to the atypicals. Is because they have such strong D2 blockade, which means that they are effective, but they do have that sort of higher EPSE thing. And then when we look at the atypicals, which are the second generation antipsychotics, so these have less extrapyramidal side effects on the whole, and that is because they have less D2 blockade than the typicals. But what they also do is they can essentially also block 5-HT2A, and then what that does is it basically is involved in some of the other aspects of the side effects, so to speak. So when basically, if the 5-HT2A receptor is activated, it blocks the dopamine release. So when it's antagonized, it increases dopamine in certain areas. So you get less of the kind of negative symptoms that you would in a typical antipsychotic, if that makes sense. So basically in some of those areas, like in the tuberoinfundibular pathway, for example, it has less blockade, so you get less of a high prolactin. And again, the same for sort of the EPSC type of thing as well, because it doesn't cause sort of decreased dopamine in the nigrostriatal areas. So other things to note are that there is obviously a move towards using the atypicals more, but this doesn't necessarily correlate in studies to increased efficacy or increased kind of compliance. There hasn't been a lot in the difference between those two things, and the main differences are in the side effect profile. So I said the D2 blockade focused on in the typical antipsychotics causes more of that EPSCs and things, whereas the main side effects in the atypicals or the second generation are less EPSCs but more kind of metabolic type of side effects, so like weight gain or that metabolic syndrome type of effect. So that would be the key thing to note. And the ones in there are the aripiprazole, clozapine, olanzapine, quetiapine, amisulpride, risperidone, and ziprasidone. But it's worth kind of knowing about this 5-HT2A business, because that does kind of that is kind of like the key difference between the two of them. So yeah, that is probably the most part on the antipsychotics. And then I noticed that when I was looking at this earlier that I made a mistake on the where I put pimozide twice. So that's just the second pimozide actually should be just that row should not be there, because dibenzodiazepine is clozapine and diphenylbutylpiperidine is pimozide. So just ignore that extra line in the middle. I think I was a bit tired when I was finishing this up. So let's just run through those to try and remember them. So the aliphatic phenothiazines include chlorpromazine and promazine. Piperidine phenothiazines include thioridazine and pipothiazine. The piperazine phenothiazines are fluphenazine and trifluperazine. I think the top three are probably like the most hard to learn. Again, I think I just made flashcards for these. After that, it gets a bit better, I think, although I'm not sure really. Butyrophenones, haloperidol, I feel like that one's fine. Thiazanthines, flupentixol and zuclopentixol. Diphenylbutyl piperidine is pimozide. Ignore that next line. And then the dibenzodiazepine is clozapine. Benzoxazoles, risperidone. Thienobenzodiazepines, olanzapine. And dibenzothiazepines, quetiapine. Substituted benzamides, sulpiride and amisulpiride. And then the quinolone, which is arylpipirol. I can't. That's aripiprazole. So again, I don't really know whether it is helpful just seeing it in a table like that, because these are really, really tricky just to memorize. But again, flashcards, or maybe if you can say them, maybe you could read them out to yourself and record it and play it for yourself. I definitely didn't do that for this one. I think I just wrote them out because these are a bit tough to memorize, to be honest. And I don't even think it works with like a mnemonic, because the words are so similar that they just all kind of blend into one. But there are a few that still sort of stick out, aren't there? Like butyrophenones, haloperidol, the thiazanthines, the substituted benzamides, the quinolone, the benzoxazole. I think those are okay. And then maybe if you can remember that dibenzodiazepines, clozapine, and dibenzothiazepine is quetiapine, then maybe you can remember that. So maybe if you're thinking about that, dibenzothiazepine is a Q, so TH and a Q, so maybe like the Queen. I don't know. If anyone can think of anything good to remember that by, then definitely let me know, because I haven't been able to think of anything. So in the syllabus, we covered the placebo effect, and you'll probably know a lot about this already, but the key things for the exam are this thing called placebo sag, which is a decrease in the placebo effect with repeated use. The fact that it works best with kind of things like pain and like a lot of physical health things that involve like the autonomic nervous system. But they're also obviously a good response with some of the psychiatric disorders, not all of them, but like things like depression, anxiety, and a little bit in like mania, but obviously less when it's more when there's like a stronger organic component, then it is less strong. The relationship between patient and doctor is very important for how well the placebo effect works, and also the patient's expectation as well. Things like capsules are stronger than tablets, and anything that makes it look like it's more intense, like more dramatic, has a better effect. So like giving someone a massive injection of like bright green liquid is going to have a much better placebo than like just giving them like a very tiny white tablet. And there are some theories about why the placebo effect works, and some of these include kind of conditioning, so behavioural things, but also the fact that they may create endogenous opioids through sort of certain mechanisms, like having that mental visualization that you're being given something can basically create these endogenous opioids, or kind of like factors within the body that can basically reduce pain or help with certain things. So those are some of the theories with that. And then moving on to compliance and adherence. So these are just terms that can come up potentially in EMQs. So compliance is how much a patient's behaviour corresponds to medical advice, and this is quite specific about the patient's like that's their only job, like everything is on them to do it. whereas adherence is similar to compliance, but there's kind of like an aspect which is that the clinician is somewhat involved in helping the adherence, so like providing information, providing the treatment, or assisting in some way in their treatment plan. So but they are quite similar in terms of their description and in clinical, like in studies and in papers. There's not like a whole lot of difference in terms of terminology. Yeah, there's been like lots of various different papers that use it in different ways, so I wouldn't sort of stick on one type of meaning for it as such. And then concordance is described in some places again as the therapeutic alliance between the prescriber and patient. So this is like the kind of like going along with it, how is it going, basically, is a concordance in terms of therapeutic aspects. And then you can measure the compliance or adherence through different types of measurements. So things like for example, I recently read a paper about CPAP adherence. They used the machine, and it showed like how much time they'd spent using the machine. So from that they could collect like how many hours a night that the person had used it. So that's pretty straightforward. And then the other thing is that there's a health belief model of adherence, which outlines 4 main belief categories that a patient considers before they make a decision for prescribed medications. And these 4 things are the benefit, the cost, the susceptibility, and the secondary benefits of medication and adherence. So that's the only other thing for that, which is the health belief model of adherence. Then in terms of adherence, these things do not have any influence, which I found surprising. I would have thought that marital status would have affected. And actually, I think it does affect, because in that CPAP paper, for example, it did affect like whether the person had a partner affected their adherence to the CPAP. So I would take these with a pinch of salt, to be honest, because they're very, very specific for, I mean, adherence and compliance can be very, very specific for various different treatments. So I think maybe if we're talking purely psychiatric stuff, but then again, I would also disagree with these. Socioeconomic status would definitely have an effect. So would marital status. So anyway, but this is what like the sort of notes say that are kind of out there for RC Psych revision and things. So yeah, pinch of salt, but this is what supposedly the syllabus thinks. And then these things reduce adherence, which I would agree with all of these. So homelessness, comorbidity, drug and alcohol misuse, cognitive deficits, polypharmacy, chronic disease, high frequency of medication, history of non-adherence. So that's all quite fair. So anything that you could think of that would be a barrier to adherence is a barrier. And then these things increase adherence. This is why I don't agree with the marital status thing, because that was technically considered family. So family support, using an alternative form that's like easier, like liquid, sublingual, I think even like depot, anything that's not tablets, basically. Good clinician relationship, good access to healthcare, and high enthusiasm from the prescriber. Yeah, that's pretty nice, really, isn't it? I suppose you always want someone enthusiastic to be prescribing a medication. I guess it means like giving you all the information, encouraging you to take it, and doing follow-ups and things. These are the things that improve adherence, so psychoeducation, compliance therapy, motivational interviewing, behavior modification interventions, cognitive-based interventions. So basically any kind of therapeutic intervention, talking therapy that can kind of assist the person in structuring their treatment and improving their adherence. And then coming to drug regulation, so this is sometimes asked, like what phase are human trials used with volunteers? So, okay, we'll go through these. Basically, all drugs have to be approved in this way. They have to have these steps before they're approved by the council in the UK that does medical health regulation. So number one is the preclinical animal studies. So this is before the approval and marketing start, and then they basically use the animal studies on at least 2 different animal species, and they study the how toxic it is, if it can cause cancer, any of that stuff. So the second one is the human trials volunteers phase 1, which is investigating mainly safety. So this is saying how safe is this for humans? They use a very small amount of people and also a small amount of the drug generally, and they are testing kind of tolerability and the pharmacokinetics of the drug. Then the next one, phase 2, is for human trials in patients. So this is looking at effectiveness on a target disease compared to placebo. So if it's just to see if it does actually work against a specific disease. And the main methods are the RCTs and the controlled trials, and they're generally still quite small trials. Then the next phase is the phase 3 superiority trials, which are basically looking, these are double-blind randomized control trials, which kind of compare to what's the current treatment, look at how effective the treatment is in terms of in relation to another. So say, for example, sertraline versus fluoxetine. And then the next phase is the human trials post-marketing surveillance, phase 4. So that's if everything else has been done and it's gone okay. And then they kind of do look at the more sort of rare side effects, I guess, when after there's large scale prescribing, and then it kind of undergoes the approval process in this phase 4 post-marketing surveillance stage. That's pretty much it for drug regulation, to be honest. Then in the syllabus, it has this thing called Principles of Rational Prescribing. So this is kind of what I gathered that they meant, and that is that they want somebody to know that, we prescribe the lowest dose for the shortest amount of time. We should have therapeutic monitoring for dose-dependent drugs, for example, like lithium. We should do metabolic monitoring for drugs that can affect things like olanzapine. Prior to actually giving medication such as antidepressants, we can have a period of watchful waiting to see if there's any improvement. That's actually indicated by NICE. Monitoring response and follow-up. So it's the duty of the prescriber or clinician to follow up to see if the medication or treatment is working. We would be trying to avoid using multiple medications at once or having too many medications prescribed. Obviously, informed consent, autonomy, and patient choice is paramount in every interaction with prescription. And off-label use is allowed, but it has to be really explained to the patient, should be very specific, relevant, of what you kind of need to use it for, and there can't be anything else that would be better to use in that situation. Or if there is a good reason, it has to be kind of documented clearly. And then long-term prescription should be reviewed and guidelines should be followed, which kind of goes without saying, to be honest. So that's principles of rational prescribing. I feel like they're quite common sense principles, but sometimes it's good just to remember them specifically for if they do come up. So that was a quick whiz through general stuff that's on the kind of first section of the syllabus. And then we're kind of moving on to pharmacokinetics. In this one, we're looking more at these types of stuff like that zero order kinetics and the CYP 450. So with the kinetic changes in health, such as pregnancy, I'm actually going to cover that in the next session because there's kind of a bigger section in the syllabus later, sort of further down on pharmacodynamics, where they talk about kind of older age and other stuff. So I'll cover it in that. And then blood-brain barrier we actually covered previously, and these are the kind of things that are where is it most permeable, that area posterior circumventricular organ stuff. So we'll just see what we'll cover, to be honest. So I'm sure all of you are kind of familiar with these. These are the general principles of pharmacokinetics, really, which is that absorption, distribution, metabolism, and elimination. So different stages of taking the drug in, it being distributed in the body, metabolized to, its active metabolite, or utilized essentially, and then excreted through elimination. And the mnemonic for that is ADME, ADME, to remember that. And then we're looking at the effect of mode on administration of kinetics, which is essentially when they write that in the syllabus, what they mean is what route makes the most difference in terms of kind of absorption and things. And we know that first pass effect occurs with oral administration rather than, for example, IV has the best bioavailability. It has no first pass effect, and that is 100% bioavailability. Things like having poor oral absorption can lead to lower bioavailability. Things like gastric emptying, sort of area available for absorption, the pH in the intestine, like things like, for example, Crohn's or like UC, that kind of thing. And then enteric coating, which is when you have like a tablet coated with another layer which breaks down, disintegrates more slowly. This slows down the absorption by affecting the disintegration rate. And then things like the liquid form is more quickly absorbed, which we do know, and that would make sense because it doesn't have to be disintegrated first. And then IM administration, this is absorption over around 10 to 30 minutes, and it does also avoid most first pass metabolism. So those are the kind of key points for effective mode on administration of kinetics. Then we look at protein binding. So this is also specifically mentioned. When they say protein binding, what they mean is knowing that when a drug is taken into the body, some of it is bound to like plasma proteins which are in the bloodstream. And when they're bound to these plasma proteins, they're unable to kind of have any effect on like a receptor because they're kind of bound, and that's changed their shape and their structure and everything. So the only useful basically parts of the drug are the parts which are the free fraction, and that is the unbound fraction of the drug, because it can sort of stay available and bind to receptors. So this affects the distribution of the drug, which basically just means where in the body is the drug, like in what kind of area. Is it like in the bloodstream, or like in the plasma, or in the, in the muscle if it's given IM, or wherever. And then this distribution and protein binding, these are affected by different factors like permeability or the lipid solubility of the drug, and also hemodynamics. So for example, organs that get more blood flow, they will have different kind of amounts of distribution, like liver, kidney, or like heart or brain. That's basically it on the protein binding aspect. And then just looking at the a reminder of the equation for the volume of distribution. So when we're looking at this, this is basically the amount of the drug, so the dose, divided by the concentration in the plasma, and that gives you the volume of distribution, which depends on the lipid or water solubility of the drug itself. I think just learn that equation because it can come up as a sort of working out type of question. And then moving on to the linear versus zero order kinetics. So I think it looks worse than it is, and I'm sure pretty much all of you probably have figured it out by now on your own from kind of doing questions and things, but I'll just touch on it briefly anyway as a reminder. So basically, drugs have these two different types of clearance when they are taken in, or like they've been absorbed. So after they've been absorbed, they kind of get cleared through the body in these two different types of ways. So when there's a constant fraction, so the same amount of drug is cleared per unit time, this is called first order kinetics. And then So there's a proportional increase. So the higher amount of a drug that's present, the faster elimination. So there's exponential decay versus time. So whereas in the zero order kinetics, there's basically a constant amount of drug eliminated per unit time, and you've got that kind of clear line that goes down. So yeah, the main example they use for that is alcohol for the zero order elimination. But like a lot of the medications and drugs usually are sort of first order elimination. That's kind of all there is to it, to be honest, keeping it simple, really. So yeah. And then this is the area under the curve. So again, another concept which is a bit sort of comes up occasionally, but what we're looking at here is kind of the overall drug exposure. So that like how much drug has basically been like effective in the body almost. So in that curve, you want to have the top of the curve is the highest concentration of drug in the blood. So you wouldn't want that to go above the therapeutic index, and that should be somewhere like within that curve. And then you can see the half-life is the time at which the drug has, the time it's taken to reduce by half, essentially. And I think all there is to remember really is that area under the curve means the overall amount of drug that the person has been exposed to, technically, like in terms of absorption and utilization. So just mention the therapeutic index. So that would be kind of within the area under the curve. So that kind of section, going above the therapeutic index causes toxicity. So yeah, in the therapeutic index, this is the range where the medicine is effective, and what you're trying to do is avoid toxicity and stay within a region that actually improves the outcome of the person. So there's a few drugs which have quite a narrow therapeutic index. Those are gentamicin, digoxin, warfarin, phenytoin, lithium, and carbamazepine, which I'm sure you probably already know because we do end up covering those sort of in medicine as well, in gen med, and knowing about those too. So another useful exam point is the P450 enzyme inducers and inhibitors. And again, I'm keeping most of this stuff like pretty simple and back to basics with these, because we want to just try and make sure we revise the key stuff, and that before going into some of the more complicated things. Essentially, the enzyme inhibitors, so these are cimetidine, chloramphenicol, fluoxetine, isoniazid, ketoconazole, valproate, and ciprofloxacin. And the inducers, the most common ones are phenobarbital, rifampicin, carbamazepine, phenytoin, and griseofulvin. There are lots of mnemonics online to learn the enzyme inhibitors and inducers. I think the one I learned was called I don't know, I think it was quite rude, so I probably better not say it here. But yeah, there's lots of things to revise for that in terms of memorizing. So specifically, now we're looking at relevance to our psychiatric kind of drugs and medications. So the enzyme CYP1A2, so these drugs are metabolized by that enzyme. So clozapine, olanzapine, asenapine, agomelatine, and melatonin are metabolized by CYP1A2. So fluvoxamine actually inhibits that enzyme, which raises the concentration of those drugs. So yeah, so never give. I think in the question I would say, contraindicated is fluvoxamine with, asenapine or olanzapine, because well, maybe not completely contraindicated, but caution, or have to be very careful because that can raise a drug concentration. And then barbiturates actually induce that enzyme. So they would cause a decrease in the amount in the body. So if you have a barbiturate with clozapine, olanzapine, cenobamine, agomelatine, or melatonin, they would have a lower, they would have a shorter time, a shorter half-life essentially, because they would be metabolized more quickly. And then CYP2D6 metabolizes amphetamines, atomoxetine, aripiprazole, clomipramine, fluoxetine, olanzapine, risperidone, mianserin, imipramine, venlafaxine, and Zuclo. And yeah, basically, I'd say probably like, I guess that one does most of them. And then inhibitors of CYP2D6 are fluoxetine, paroxetine, bupropion, acenapine, and amitriptyline. So again, would be caution with using some of those together. Although they do get used together sometimes, don't they? Sort of things like fluoxetine and other things. So yeah, I think basically, the main thing, actually, that is the point to note, that fluoxetine does inhibit and metabolize it as well. So get metabolized by it. So that is one thing to note for CYP2D6. But yeah, again, caution in the exam question about mixing those up, basically mixing them together. And then CYP3A4, aripiprazole, clonazepam, donepezil, fentanyl, methadone, mirtazapine, quetiapine, and zopiclone are all metabolized by CYP3A4. And then fluoxetine and paroxetine are inhibitors of this enzyme, and then inducers of this enzyme are carbamazepine, phenobarbital, phenytoin, and St. John's wort. So all of these are kind of like more specific enzymes, relating to the psychiatric drugs. After having looked at this, which is like the general ones, we're then kind of looking at more of the specific ones. Let me just see if there's anything else. So yeah, I think we've already covered that, carbamazepine, phenytoin, and the barbiturates. Also ethambutol, reduce antipsychotic levels, and then SSRIs, TCAs, cimetidine, erythromycin, Cipro, and ketoconazole can inhibit some of metabolism and increase antipsychotic levels. So yeah, I'm not sure if I mentioned at the beginning, actually, I was planning to just take questions at the end, but possibly sort of get back to people by email, just because of it being like the fasting month and everything. So yeah, please do put your questions in and things, and I'll get back to you probably individually on that. Okay, so the next thing to look at is what's known as steady state. So this is 4.5 half-lives basically of a drug being taken for it to reach like a steady plasma level in the body, and then a loading dose can help achieve that steady state more quickly. And with steady state, that's when you're looking at your therapeutic effect. So say for example, you've got drugs with a very long half-life, it's going to take a while to get to this steady state, but drugs with short half-life, it won't take long. It might take like a couple of days or a short amount of time. So important to know roughly what the half-life is of some of the medications so that you can know. And I think that does come up as a question, like the approximate amount of time, like 300 hours or like 50 hours, that's how long it takes to reach steady state in various things. So we'll just come on to pharmacodynamics now a bit more and have a look at that before we take our break. So we'll just start off with some of these. So looking at the pharmacodynamics, if you have the syllabus handy, then you'll probably know that this is the section 4.3, which looks at the kind of receptors, a bit of a reminder there, even though we have covered that already, and then looking at like agonists, and then these are the section which has some of the mechanisms of some of the antipsychotics, antidepressants, etc. So I've covered antipsychotics and antidepressants in this bit, and a little bit on mood stabilizers, and then I've also done this bit which says the major etiological theories underpinned by pharmacological mechanisms. So we've got all of those hypotheses, but some of the other ones, like the sedative hypnotics and things, I'll just save that for the end, for probably for the next session, because just to kind of focus on the key points and the most important aspects of it. But hopefully we'll cover everything, so don't worry. And if there's anything in particular that you are concerned about for next session, just as I said before, just drop me a line and then I can make sure that's included. I think some people did want certain things like covered, so I have been doing that, so I hope that's been good. So just a reminder, we have done metabotropic and inotropic receptor types before, and you probably already are sick of them, to be honest, but just a reminder that the metabotropic ones are the G protein couple receptor, receptors basically, and they include things like dopamine, D1 to 5, noradrenaline, all of the serotonin receptors except 5-HT3, which is inotropic, but 5-HT1 to 7, apart from 5-HT3, are all metabotropic receptors. And that's the picture on the right, so that big like blob thing. And then also muscarinic acetylcholine receptors and opioid receptors are metabotropic ones too. They have a slower response than the inotropic receptor, which is ligand-gated ionic channels, which have a rapid effect, and they kind of act very quickly. They cause excitation or inhibition of postsynaptic membrane. They have the nicotinic acetylcholine receptors, for example, inotropic, GABA A receptors inotropic, glutamate receptors are inotropic, and serotonin 5-HT3. So that's the only serotonin one that is not metabotropic. So just to remember that, because it's a little bit of a funny one, 5-HT3. So the concept of affinity is the ability of a drug to bind to its appropriate receptor. So when a drug binds readily, it has more affinity. So this is also linked to the concept of potency, which is that when more receptors are occupied by a drug, that means it's sort of more potent. So it kind of makes sense, really, doesn't it? So the affinity of a drug is how easily or how like readily it binds to a certain receptor, and then the more receptors that are occupied means the more potent that drug is, so higher potency. And then efficacy. So this is looking at how did the drug do what it was supposed to, and how well did it do that, essentially. And this is a multifactorial construct, so it's looking at affinity of the drug, it's looking at the potency of the drug, the duration of receptor action, so does it bind and stay binded for a while, what is the half-life. So all of these are involved with looking at how efficacious a certain drug is and how well it's produced the expected response. So agonists, this comes up sometimes as EMQs of like what different agonists or antagonists kind of do. So basically, it is worth noting that some substances can bind to certain receptors and act as agonists, and that at other receptors they can act as antagonists, and those ones are called agonist antagonists. But the rest of them, we'll just go through them. So an agonist, so generally speaking, binds to a receptor and produces a biological response. Full agonists have full efficacy at a receptor, and then partial agonists produce a response, but they never produce 100% of the response, even at their highest doses. So a partial agonist, even if you saturate with the partial agonist, it's never going to give you 100% of like a response at that receptor. That's just the nature of partial agonists. Antagonists block agonists at receptors, but they don't do anything on their own. Like they're not supposedly meant to create an effect on their own, as it sort of stands. Then inverse agonists have the opposite effect of full agonists, but they are not the same as an antagonist. So there is a difference between the two. Basically, the antagonist blocks the agonist, whereas the inverse agonist does act on the receptor, but has like the opposite effect of the full agonist, if that makes sense. And then competitive antagonists bind reversibly to receptors and don't affect the biological response. So they're just like antagonists, but they're competitive and they bind reversibly. So they're not supposed to also create any effect as well. Okay, so now we're on the kind of moving into the topic of the medications and the drugs and the kind of theories. So I think this would be a good sort of point to take a break, really. This is just what it's called in the syllabus: putative mechanisms of action of major psychotropic psychoactive classes target actions at molecular and systems level. But actually, all that means is how do some of these drugs work? That's it. Mechanisms of action of some of the drugs. So yeah, I'll just touch on these, but basically it does, as I said before, cover all of these things in this part of the syllabus, but some of these I will save for kind of later. Like I think I'll put all of the kind of what are they called, like substance misuse drugs and things into one section, because it's just easier to process like that. So in this section I've just covered mainly the antipsychotics, antidepressants, and some of the mood stabilizers, but those are probably the highest yield ones to know. So as we get closer to the exam, we'll just focus more in on the key stuff really, and cover whatever's left in the following session as well. So yeah, it's just sort of we've done nearly 50 minutes, so we'll just take a 10-minute break now and come back in 10 minutes and move on to the next section. Hey guys, so it's just coming up to 10 minutes on the break, so let's just get back into it then. So looking at the antipsychotics to start with, the first one we're going to have a look at is amisulpride. So amisulpride is a D2 and D3 selective antagonist. It has quite low affinity for D1 and D5. And it doesn't really bind to any of the non-dopaminergic receptors. It is obviously well known for causing high prolactin, and we can talk about some of the side effects later, but these are the most important things to know in terms of mechanism of action. There is some limbic selectivity and also 5-HT7 activity, and like most medications, it is dose dependent. But it is quite obvious with amisulpride because there are clinically people on various different kind of amounts of this medication, and it can be like quite patient specific about how much they take. So yeah, I guess the main thing to know is that it's D2 and D3 selectively antagonizing, and that doesn't really bind to any of the non-dopaminergic receptors. So the next one is olanzapine. So as you know, this is an atypical antipsychotic. So this is second generation, is well known for things like weight gain and the metabolic side effects. It blocks 5-HT2 and D2, as well as D4 and 5-HT6. It also has quite sort of strong anticholinergic and antihistaminic properties, which explain the some of the weight gain and increased appetite in that regard as well. And also the sedation can be related to both that anticholinergic and antihistaminic property. Again, quite popular medication to use, and requires metabolic monitoring as well. So olanzapine is quite often used. Then we've got aripiprazole. Aripiprazole is a partial agonist at the 5-HT1A and D2, as well as 5-HT2A antagonist. So it doesn't cause high prolactin, so it can actually be used to help reduce the prolactin in kind of as an adjunct combination therapy, because it doesn't really affect the tuberoinfundibular pathway. It also acts on postsynaptic D2 receptors and also presynaptic autoreceptors. So another thing to note is it exhibits something called Goldilocks phenomenon, which is basically where it antagonizes dopamine in places where there's a lot of dopamine. So, for example, the mesolimbic zone, whereas it agonizes in dopamine deficient areas. So that helps with avoiding negative symptoms, and also again like this not causing increased prolactin as well. That is also related to that. So this Goldilocks phenomenon where it basically reduces it in high places and increases it in low places. So seems like quite an ideal drug, really. The next one is clozapine. So clozapine obviously is very popular, becoming more and more popular. Difficulties related to kind of monitoring, like the FBC, all of that kind of stuff, which I'm sure you guys all know from your own clinical practice, can be a bit of a hassle, to be honest, but has very, very good outcomes for patients. So clozapine has a high affinity for D4 and 5-HT1A, is a partial agonist for that, and also is a 5-HT2 antagonist as well. It does cause alpha-1 antagonism, and is also has anticholinergic and antihistaminic properties as well. It has some D1 and D2 affinity, but it's quite weak, and it also binds 5-HT3, and it's got quite a fast association rate. So when it binds to like a receptor, say D4, it kind of does its job, and then it kind of unlinks itself quite quickly. So This is known as kind of like a hit and run profile, I guess, and I think it also is mentioned later in one of the other medications, so we'll see that as well there, but that's just one thing to note about clozapine. And then moving on to lorazepam. So lorazepam is a D2 antagonist, also 5-HT2A, 5-HT2/7, alpha-2A and alpha-2C adrenal receptor antagonist, and is also a partial agonist at 5-HT1A. So luckily it has kind of low affinity for alpha-1, so it doesn't cause as much kind of postural hypertension and things like that. So it's more looking at alpha-2A and alpha-2C rather than alpha-1, so it doesn't have as much effect on that, and also doesn't have as much affinity for histamine receptors, which means that it could be possibly weight neutral, although I haven't really checked this fact to see, because, you know, I think most of the atypicals do have kind of some metabolic or like weight gain effects. So I think they propose that because of its lower affinity for histamine receptors, that means that it probably causes less weight gain overall, but this remains to be kind of fact checked, I guess. And then we're looking at risperidone. So risperidone is a serotonin and dopamine antagonist. So it's an atypical antipsychotic, second generation, and it's got works quite strongly against 5-HT2A receptors, and it can also cause extrapyramidal and hyperprolactinemia side effects in higher doses as well. So just remember that 5-HT2A antagonism as well for risperidone. And then looking at sulpiride, so the difference between amisulpride and sulpiride is that amisulpride does a D2 and D3, whereas sulpiride just does pure D2 antagonism. Interestingly, in sulpiride, in lower doses, it blocks the presynaptic receptors and helps with some of the negative symptoms, whereas in higher doses, it blocks a lot of the postsynaptic D2 receptors, which helps with the positive symptoms. So it kind of is a bit of a dose-dependent drug as well in that regard. So that's quite interesting to note from a clinical perspective about sulpiride. And then quetiapine, this is the other medication that has that hit and run thing on D2, so it will bind quickly to D2 and make its effect, and then kind of rapidly dissociate from that receptor. It has obviously got anticholinergic effects, but it does have less 5-HT2A blockade compared with the other second generation atypicals, and supposedly the side effect profile for quetiapine is meant to be quite good. So moving on to the antidepressants, so got quite a lot of them, to be honest. So we'll just start with the SSRIs. These are the main SSRIs that are popularly asked about. So citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline. And so starting off with citalopram. So with citalopram, this is the only SSRI that can increase the QTc, and this is a dose-related increase as well. So the higher you increase the dose of citalopram, the more the QTc can potentially increase as well. It's got a half-life of 33 hours, and it's got all of these side effects, which are kind of like the common side effects that you get with all of the SSRIs. So nausea and vomiting, abdominal pain, rash, sweating, agitation, anxiety can be increased when starting or even during treatment, tremor, insomnia, sexual dysfunction, hyponatremia is quite common, cutaneous bleeding disorders, diarrhea, and dyspepsia. It does not interact with cytochrome enzymes, which is good, and the minimum dose is 20 milligrams per day for citalopram. So key things to note is the QTC relevance, and obviously has all of this side effect profile, but then again, a lot of the SSRIs do. So escitalopram, again, it does have the same side effects as citalopram as well. Has a half-life of 30 hours, which is 3 hours shorter than citalopram. But again, we're looking at all of these same side effects. So nausea and vomiting, abdominal pain, rash, sweating, agitation, anxiety, tremor, insomnia, sexual dysfunction, all of those things. It's worth knowing just all of those because they are basically the main ones for SSRIs. So that's escitalopram. And then moving on to fluoxetine, so very, very commonly used medication, half-life of 4 to 6 days, very long half-life, takes a long time to get to steady state for fluoxetine. Again, all of those same side effects, but insomnia, agitation, and rash are more common with fluoxetine than with the other ones. Can affect insulin kind of levels, so the dosage needs to be reviewed. Inhibits CYP2D6 and CYP3A4, is contraindicated in use with monoamine oxidase inhibitors, and avoid prescribing it with St. John's wort and selegiline as well. So, as you know from the enzyme-inducing things, it does increase the level of some medications, enzyme inhibiting. So, just to be aware of that potential risk. But the main thing is the long half-life and contraindication with MAOIs, and avoiding that co-prescribing with St. John's wort and selegiline as well. Fluvoxamine, this also has quite a long half-life, obviously not as long as fluoxetine, but 17 to 22 hours. Actually, I suppose that's not that long. That's less than a day. So it just sounds quite long, doesn't it? So it has the same side effects as the rest of the SSRIs as well. Actually, just one thing I wanted to note, which I've written on my notes about fluoxetine, is I've written about the half-life, which is that the half-life does increase when you use it more, when you continue using fluoxetine more. So it goes initially from 1 to 3 days, and it increases to 4 to 6 days, because fluoxetine and its own active metabolite inhibits its own metabolism. It basically inhibits itself and creates itself a longer half-life and stays in the body for longer, essentially. And we did say also increases levels of some medications. That includes some of the antipsychotics, some benzos, carbamazepine, cyclosporin, phenytoin, and the tricyclic antidepressants as well. So just to be aware of that. Sorry, so we were on fluvoxamine. So fluvoxamine, half-life 17 to 22 hours, same side effects as the rest of the SSRIs. You get more nausea with fluvoxamine, and it inhibits CYP1A2, CYP2C9, and CYP3A4. And again, that can also increase some of the medications such as warfarin, clozapine, TCAs, and methadone. So there's a lot of sort of difficulty with the co-prescription of these. And I think usually I just use the BNF to make sure checking, but for the exam, I think it's worth remembering some of these, especially for things like fluoxetine and sertraline, the main ones. So coming on to paroxetine, so this has a half-life of 22 hours. Again, has some of the same side effects as the other SSRIs that were mentioned. So all of those other things are relevant and important side effects for paroxetine too, but it also has an antimuscarinic effect and has a strong sedative effect too. It inhibits CYP2D6 and CYP3A4, and also increases some of the medications too via these inhibitions of these enzymes, so some of the antipsychotics and tricyclics as well. Again, paroxetine is contraindicated with monoamine oxidase inhibitors, and also advised to avoid St. John's wort as well, just because of that inhibition with those cytochrome enzymes can basically make you have risk of basically having serotonin syndrome, essentially. So then sertraline, which is a favourite, which has a half-life of 26 hours. Again, similar side effect profile to the other SSRIs. So all of that stuff like nausea and vomiting, etc. This inhibits CYP2D6. Advised to avoid St. John's wort with this too. And it does also increase some of the antipsychotics and TCA levels because of that inhibition of CYP2D6. And if you go back to, if you remember that previous slide, which I can go back to at the end probably, but that slide has the kind of which antipsychotics and things are done by which enzymes. So yeah. And then moving on to some of the tricyclic antidepressants. So what we're looking at really is generally these tricyclics. So low-dose amitriptyline is often used for neuropathic pain and headache prophylaxis. Lofepramine, and these are just kind of like some of the key facts that are relevant for tricyclics. Lofepramine has the lowest incidence of toxicity and overdose. It's a key thing to note. Amitriptyline and dosilepin are the most dangerous in overdose because of that cardiac risk. Secondary amines have a lower side effect profile and act primarily on noradrenaline. So secondary amines, which we'll talk about in a minute, which ones are secondary amines, basically have a lower side effect profile. And then tertiary amines boost both serotonin and noradrenaline. So secondary does just noradrenaline mainly, and then tertiary does serotonin and noradrenaline. And we'll come to which ones are which in a moment. And then discontinuation symptoms are worse with amitriptyline and imipramine. So these are the kind of like sort of key exam style high yield questions that are often asked for those, and I'm sure you've come across those in questions already. So hopefully that's relevant to your revision. I've put two pandas here because so it's how I remember this is like PAND and then A2, which is amines 2, like secondary amines. So PAND is protriptyline, amoxicillin, nortriptyline, desipramine, and I put two pandas there because they're secondary amines. So panda 2 is the mnemonic I use for secondary amines. So yeah, protriptyline, amoxicillin, nortriptyline, and desipramine. And again, these also, as I said before, secondary amines tend to act primarily on noradrenaline, and they have a lower side effect profile than the tertiary amines. And these are the tertiary amines, which are the first generation, and they are amitriptyline, lofepramine, imipramine, clomipramine, dosilepin, doxepin, trimipramine, and butriptyline. So these are all the first generation tertiary amines, basically. And having a look at some of the side effects for the tricyclic antidepressants. So they cause antimuscarinic side effects, which can include dry mouth, urinary retention, kind of tiredness, all of that antimuscarinic stuff, slowed gastric output, constipation, all of that kind of thing. That's all antimuscarinic related. And then you've got the antihistaminergic side effects, so weight gain, drowsiness, everything is run by histamine. So histamine is obviously important in your circadian rhythms and generally like your sleep-wake cycle. And then antiandrogenergic, so they can cause postural hypotension, sexual dysfunction, and cognitive impairment. Antiserotonergic side effects as well, so weight gain is one of those, and then membrane stabilization can be affected by tricyclics, which we know from the, for example, amitriptyline overdose, that kind of classic TCA overdose, can be cardiotoxic and also reduce the seizure threshold as well. So that's just something to be aware of. And there are many more side effects of TCAs. So these include the arrhythmias and the ECG changes, this thing called black hairy tongue, where they get like a black hairy tongue, basically. And it's like the filiform papillae, like the little hairs on the tongue, become long, and like the ends of them like turn black. I think maybe because they necrose or something, but apparently it's like it's not harmful at all, but it's just a side effect of TCAs. Sounds quite distressing though. Tremor, altered LFTs can be affected by tricyclics, paralytic ileus, which is dangerous, and then neuroleptic malignant syndrome, which we'll cover probably in session after next. So under classifications, probably going to do serotonin syndrome and neuroleptic malignant syndrome in that as well. So just revising some of the mechanisms of the antidepressants. So we've already done a lot of the SSRIs basically, but looking a little bit closer at the mechanisms. So mirtazapine is what's called a NASA, and it's also a 5-HT2 antagonist, 5-HT3 antagonist, H1 antagonist, alpha-1 and alpha-2 antagonist, and a moderate muscarinic antagonist. Again, quite hard to remember these, but I think, just going over questions a lot just helps. I think most people remember that mirtazapine's a NASA. Could just think of like a rocket or something. And then venlafaxine and duloxetine are both SNRIs. Reboxetine is a NARI. St. John's wort is a weak MAOI and SNRI. Trazodone is an SARI, and it also blocks the SERT, so that's the that transporter, and the antagonists at 5-HT2A and 5-HT2C. Moclobemide is a reversible inhibitor of monoamine oxidase A. Agomelatine is a melatonergic agonist, so that's MT1 and MT2, and it's also 5-HT2C antagonist. And then bupropion is a norepinephrine dopamine reuptake inhibitor, which is called an NDRI, and is also a nicotinic acetylcholine receptor antagonist. And I know that is a lot of stuff to remember in one slide, and yeah, these are just kind of like the key things that you probably hopefully know already by now about each of these medications, but again, worth revising. If not, this is kind of the very basic, most essential kind of level that you should already kind of know about these medications, to be honest. Then the monoamine oxidase inhibitors, so just a bit of background on them. So they were, just make sure I've covered that, yeah. So they were first introduced in the 1950s, and they were the first antidepressants that were kind of introduced, and they are quite useful for atypical depression. So these receptors are found in different places. So monoamine oxidase A is found in the placenta, the gut, and the liver. Monoamine oxidase B is in the brain, liver, and platelets. And serotonin and noradrenaline are substrates of monoamine oxidase A. And then phenylethylamine, methylhistamine, and tryptamine are substrates of monoamine oxidase B. And then dopamine and tyramine are metabolized by both monoamine oxidase and monoamine oxidase A and monoamine oxidase B. So that's just the enzyme that that breaks it down, basically. So yeah, the monoamine oxidases are kind of less popular nowadays, just because of that risk of the cheese effect. Also, the risk of serotonin syndrome is increased because of also from polypharmacy as well. These are some of the key ones that are relevant in terms of monoamine oxidase inhibitors. So selegiline, this is a irreversible selective monoamine oxidase B inhibitor, but in high doses it also inhibits monoamine oxidase A. Rasagiline inhibits monoamine oxidase B. Moclobemide is a reversible monoamine oxidase inhibitor. And then transcypramine, phenolzine, isocarboxazid irreversibly inhibit monoamine oxidase. I think this is also why they are less popular, because, for example, an overdose, it can be a bit more dangerous if you have an irreversible inhibitor of the receptor. So those are just the key ones to note. So selegiline, rasagiline, moclobemide, transcypramine, phenolzine, isocarboxazid. And then looking at some of the side effects for the monoamine oxidase inhibitors. So with these, you've got the orthostatic hypotension, daytime sleepiness, insomnia, nausea. So a lot of kind of like drowsiness, fatigue type side effects with that, as well as weight gain, muscle pain, myoclonus, paresthesia, which are all quite unpleasant. Sexual dysfunction, the tyramine effect, and then, as mentioned before, you can get the serotonin syndrome with the concomitant SSRI use, which is why it's not recommended to use SSRIs with monoamine oxidase inhibitors at the same time, just because of that increased risk, really, of serotonin syndrome. And we've been through these before, but this is just a little reminder, just in a different kind of format, to look at how those work. So they're mirtazapines and NASA, venlafaxines at SNRI, trazodone, I'm not sure we covered that, but is a 5-HT agonist, a weak SRI, St. John's wort is a weak SNRI, and a weak monoamine oxidase inhibitor as well. Duloxetine, again with venlafaxine, is an SNRI, reboxetine is an NARI, and bupropion is an NDRI. So that's just some quick revision about the mechanisms of those antidepressants as well. And just coming on to some of the mood stabilizers. Again, this is just a whistle-stop quick review of the mechanisms, and just to kind of jog your memory with some of these. Valproate is a GABA agonist and an NMDA antagonist. Gabapentin is a voltage-gated calcium channel binder. Topiramate is a GABA agonist, an NMDA antagonist, and a sodium stabilizer, sodium channel stabilizer. Carbamazepine also stabilizes sodium channels. So does phenytoin. And then lamotrigine also does that, as well as being an NMDA antagonist. And lastly, pregabalin is a ligand for alpha-2 delta subunit of the voltage-gated calcium channels in the CNS. So I'll just give you like a couple of seconds to read that again. I know that I do tend to whiz through everything quite fast and rush through a lot of the important stuff. So I know that this is already quite well documented in a lot of the revision notes that are out there already, but these are really important aspects of revision. So I would definitely encourage just to take a minute to revise those properly before we move on to the next bit. So as said, going to cover some of the other medications later, and move on to some of these what is called in the syllabus major etiological theories underpinned by pharmacological mechanisms. So this is actually not covered particularly well in a lot of the available revision notes that are out there, and this is sort of has its own section in the syllabus, so it's definitely worth kind of having an understanding about. And I will explain kind of each of these theories in a bit more detail, just enough detail that you would recognise it in the exam and know what to put as the answer, really. So just get the next bit up. So yeah, with the dopamine hypothesis, this is pretty simple, to be honest, and I think most people know that. Basically, the theory is that dopamine transmission causes schizophrenic symptoms, hyperactive dopamine transmission. So when there's increased dopamine sort of around in the system, that causes the positive symptoms of schizophrenia. And this hypothesis was developed after Arvid Carlson discovered dopamine as a brain neurotransmitter. So that is essentially the dopamine hypothesis. There's a bit more kind of detail to it in terms of like where and like what kind of neurons and stuff, but essentially that is basically it. And then the biogenic amine hypothesis. So this basically states that depression is due to a reduced functional activity of amines in the brain. So there are 5 established neurotransmitters that are classified as these biogenic amines, and they are dopamine, norepinephrine or noradrenaline, epinephrine or adrenaline, and then histamine and serotonin. So those 5 neurotransmitters are called the biogenic amines, and this hypothesis basically states that depression is due to reduced functional activity of these amines in the brain. So when you look at the syllabus in this section, it kind of just states the biogenic amine hypothesis, and it sounds like quite a complex thing, but when you distill it down to kind of its key components, this is kind of all there is to it really, in essence, as such. So just to know that those 5 are the biogenic amines, and that the theory is that depression is due to reduced functional activity of those in the brain. And then moving on to the cholinergic hypothesis. Again, this has been kind of touched upon in looking at things like Alzheimer's, but essentially what this theory is looking at is that there is a dysfunction of the cholinergic neurons in the brain, which are the neurons that use acetylcholine to kind of as a neurotransmitter. And basically, when there's a dysfunction of those cholinergic neurons, that contributes to the cognitive decline of normal aging, but also it is essentially what this states is that this is the pathophysiology of Alzheimer's disease in terms of symptoms. So something that messes up the cholinergic neurons causes the cognitive decline in people with normal aging, getting very old, and Alzheimer's disease. So that is the cholinergic hypothesis, and it relates specifically to cognition. This is the cholinergic adrenergic hypothesis. So in the syllabus, it says the cholinergic adrenergic balance hypothesis mood. So when I was looking that up, I could only find it as the kind of cholinergic adrenergic hypothesis. And I think when it says balance and mood, it just means like the balance of the two, which is explained by this theory. So it's a balance of those two things that relate to mood, in particular mania and depression. So this was a hypothesis that was proposed in around 1972, and essentially it proposed that the underlying mechanisms of mania, so elated mood, are caused by having high adrenergic activity, which is more amines. So those biogenic amines like dopamine, adrenaline, noradrenaline, serotonin, and histamine are increased in mania, which would fit. And then that depression is caused by having more cholinergic activity in relation to the adrenergic. So there's more acetylcholine around, and there's less like of those biogenic amines, and that's what causes the state of depression in this hypothesis. So just remember that high mood or mania, that's more amines, high adrenergic activity, and that's what causes it in this hypothesis. And then depression is caused by having more acetylcholine, so sort of more cholinergic and less adrenergic, less amines around, which makes sense, having kind of less dopamine, less serotonin, less noradrenaline, that kind of thing around. So that is essentially what is kind of the theory of this cholinergic adrenergic hypothesis. And then we move on to the glutamatergic hypothesis, which again is outlined in the syllabus. So this specifically states that in the glutamate hypothesis of schizophrenia, basically the symptoms of schizophrenia are caused by having too much glutamate released, which is due to reduced functioning of the NMDA receptors, and that in the brain areas such as the prefrontal cortex and the hippocampus, these are the most affected parts of the brain in this hypothesis. So like in schizophrenia, NMDA receptors are working very poorly in those areas, and that's why there is these symptoms of schizophrenia and also of cognitive impairment, and that's due to excessive glutamate release because of the hypofunction of these NMDA receptors. I would say like maybe that this hypothesis would fit in part, like in conjunction with some of the other hypotheses, like the dopamine hypothesis. Potentially maybe explains the cognitive impairment somewhat in schizophrenia, but I don't think it explains the kind of psychotic aspect or psychotic element. So I guess when you're referring to the glutamatergic hypothesis, you would be remembering NMDA receptor hypofunction, excessive glutamate release, and prefrontal cortex and hippocampus most affected with kind of cognitive impairment in schizophrenia. But yeah, in this hypothesis, it also suggests that the normal, kind of like other symptoms of schizophrenia also due to this reduced NMDA receptor and increased glutamate. So I'm not sure how people feel about that hypothesis. And then just coming up towards the end really, but this is the amyloid cascade hypothesis. And again, I feel like I've rushed through everything, but I have. So this is the last kind of hypothesis that we're covering, which is the amyloid cascade hypothesis. So this theory is about Alzheimer's disease, essentially. So it says that the initial event which triggers neuronal degradation in Alzheimer's disease is enhanced by amyloid, beta amyloid generation and aggregation. And it suggests that if the amount of beta amyloid generated is greater than the amount that is degraded or broken down, accumulation occurs, which causes plaques, tau tangle formation, cell death, and the associated symptoms of Alzheimer's. And if we just put that in kind of simple terms, all that means is that beta amyloid plaques are responsible for Alzheimer's, and this is caused by there being more made than is being broken down at any one time. So there's an accumulation of this beta amyloid, which kind of turns into these plaques, and there's also these tau tangle formations as well. So that is essentially what it's saying, that that basically neuronal degradation is worsened, and Alzheimer's disease is basically caused by this beta amyloid plaques. So yeah, I mean, I think that fits, and that is kind of what is generally understood. This hypothesis was suggested in 1992, and I've written basically amyloid beta plaques are responsible for Alzheimer's disease. So yeah, that's essentially what there is to know about that. So great. Come up to the end of that session. I've whizzed through that really, and I think actually I could have fit in a few more things because I I went so fast that I have got a bit of time now, but hopefully the rest of the stuff that's very important and relevant we'll cover next week. The rest of the points in the syllabus. Just do message me your questions in the private chat, and I will basically get back to you. I think I'm not going to answer the questions straight away right now. I will just get back to you kind of by email with the answers to your questions. So yeah, do feel free just to put them in there and let me know if there's anything that you want, that you're struggling with for in this topic that you would like me to maybe touch on next week. Otherwise, have a really good week, and hope your revision continues to go well, and I'll see you guys next week at the same time. So yeah, speak to you soon, take care, and hope your revision is absolutely amazing. So take care, guys. Bye.